Good morning, everybody, and one more time I'd like to thank the organizing committee for inviting me to be today with you. Thanks to Dr. Riam, and it's been a pleasure to be in Bahrain for the first time. So over the next 25 minutes or so, I'll try to give a quick overview about thyroid disorders in pregnancy. I have nothing to disclose regarding this talk. So most of the talk is going to be anchored around the 2017 guidelines from the ATA that have changed the way thyroid disorders is being diagnosed. And it's very critical at dealing with thyroid disorder in pregnancy to understand what's the normal thyroid function during pregnancy and what will be the normal thyroid TFTs levels that we should be looking for. And the thyroid hormones are quite critical for the developing fetus, especially early on, because it kind of impacts the somatic and brain development, but more critical, it impacts the placental formation, the maintenance and growth of the placenta early on. And we all know the impact of thyroid hormones on the mother metabolism, generally speaking. And so status of euthyroidism is very, very critical for the developing early in pregnancy in order to maintain this pregnancy forward. So pregnancy is a stressful time for the thyroid. When I mean that, there are multiple changes that impact the thyroid function. One of the earliest things that happen due to increase in the estrogen production is that thyroxine binding globulin levels will increase. That means that these binding globulins are gonna suck up more free T4 from the circulation. They're going to be less free T4 in the circulation. And that's what we exactly see over there. Free T4 levels throughout pregnancy are actually going down. However, the total T4 is actually going up. And that will dictate, depends on what you're looking for, your normal range will be a little bit different. But the free T4 for sure, which we are now using, is actually on a decline. The HCG shares the same alpha subunit with the TSH, as you all know, but they have homology with the beta subunit, and the TSH is able to stimulate the HCG with a high concentration is able to stimulate the thyroid gland in order to produce more hormones. And what happens early in pregnancy is that the HCG levels increases quite dramatically, as you can see, and as a result of this increase, the HCG pushes the thyroid gland to produce more free T4. The TSH goes down, as you can see in this graph. More important here is that 10 to 20% of those women will have a completely suppressed TSH early in pregnancy. It's completely undetectable, and that's the normal physiology over here. So the increased demand of the thyroid gland is estimated to be overall an increase in production of about 50%. And that's divided according to the month. But more critical here is in the first month, there is an increase by about 30%. And that increases gradually over the next few months. But the demand decreases as the pregnancy goes on. And this graph kind of summarizes what I just said on these changes. Most critical here to understand are the suppression in the TSH and that happens early on, back to normal around mid-second trimester, and the continuous decline in the free T4. So what would be the best test in order to evaluate the thyroid function in pregnancy? So we normally do a TSH, and that is our test to screen for thyroid disorders. And that's not any different during pregnancy. And TSH, we use immunoassays that directly measure the TSH. They're quite sensitive for the thyroid status. We have standardized assays, and if you send the same sample to 5 different labs, there is very good correlation between them. So you'll be able to trust labs from different institutes. However, free T4 is not the best assay we have. The currently commercially available are immunoassays that do not measure the free T4, they estimate the free T4. And the estimation of this free T4 is affected by the albumin, is affected by the globulin levels. And these are changed during pregnancy as well. So free T4 during pregnancy estimation is quite poor. There are no standardized assay that we can actually shout out for, and hence looking at different lab results is quite tricky, and the correlation between different labs is very, very poor. So generally speaking, if you're managing thyroid disorders in pregnancy, stick to one lab all the way through, especially if you're looking at free T4. In the future, we might have the mass spectrometry that's able to measure the actual molecule of the free T4 equilibrium dialysis is labor intensive, and nobody is doing this anymore to have a better estimation of free T4. So we're now not talking about what's normal free T4 levels, because that's something which is very variable across labs, but we're more looking at what's the normal TSH range during pregnancy. And I just showed you the changes that actually happens, physiological changes. And we have old guidelines that are still stuck in some people's brain that came back in early and the start of the last decade, which tells people that the upper limit, the lower limit of the TSH is 0.1 milliliter per liter, and the upper limit in the first trimester is 2.5 milliliter per liter. And there are huge issues with that, because if you look at population studies across different parts of the world, including the United States, the upper limit of the TSH was much higher than the 2.5, much higher than that. And based on these guidelines, some countries like China or even India, if they use these cutoff points, they ended up diagnosing 35% to 40% of their women as having subclinical hypothyroidism because their TSH was above 2.5. That was a huge criticism, and it was a huge problem for with overdiagnosing of subclinical hypothyroidism. And even the lower limit, which has been drawn at 0.1 milliliter per liter, most of the studies are much lower than that. And if anything, they mostly hanging around the 0.05 milliliter per liter. But more important here to note that the TSH is completely suppressed in 10 to 20% of those women without, and they don't have any thyroid disorders. So what the ATA came up to say, that change the normal range, it depends on your assay. And they give a nice formula. Just subtract 0.4 from your lowest limit of normal. So in our institute, our lower limit of normal is 0.45. When we take 0.4 from that, our limit of normal now is 0.05 milliliter per liter. And then keep the upper limit of normal at 4. Don't get any higher than 4, and that will be the normal range. And that's exactly what we have in our hospital. So we're using a normal range between 0.05 to 4. However, this is the normal range based on our assay. You need to calculate the normal range based on your own assay. And I understand there are some assays that are more sensitive, and it goes to 0.35. At some point in time, we had this assay, but we stick to 0.05 because it made sense from the population studies. Now, switching gears now, understanding normal and abnormal to go to hypothyroid disorders in pregnancy. And an important part here to look for is to understand the fetal thyroid hormone production and how it evolves over time. And we know that the thyroid glands start to develop by 12 weeks, and we know that the production starts to become efficient by 18 weeks gestation. And between 18 weeks and 23 weeks, the fetus starts to reduce significantly its dependence on the mother, and if anything, starts to break down the thyroid hormone such a way that this does not get transferred to the fetus anymore. They use the iodine instead. By about 23 weeks gestation, there is very little transmission of thyroid hormone between the mother and the fetus. So that means essentially that the fetus is very vulnerable for thyroid hormone deficiency early in pregnancy, as I just initially told you, and it's very critical managing those women with hypothyroid disorders whom we know of, that we achieve either an early euthyroid status, preferably to do this pre-pregnancy and optimize their care very early on. But it also means something else, and I'm going to come back later on, that screening for thyroid disorders after the first trimester is probably meaningless, as I'm going to show you in a minute. So what are the adverse events of hypothyroidism per se? Well, the most important thing is a reduction in the chances of pregnancy, so subfertility and infertility, and a miscarriage. As I told you, thyroid hormone seems to play an important role in the development of the placenta. And if the placenta is impacted, other things can happen related to the placenta. Hypertensive disorders, which is mostly placental driven abnormality, abruption placentae, and small for gestational age, and low birth weight that can impact the fetus. There are some studies suggesting a neuropsychological and cognitive impairment in those women. However, the problem with this is the reproducibility of these studies were being quite poor, and we don't know what is the actual optimum TSH that can reduce that or can increase the risk of neurocognitive disorders. So what's important to start with those women is to start pre-pregnancy, and in order to optimize their care. If you optimize their care, subfertility is reduced, early miscarriage is reduced, And the recommendation is to always aim for a TSH of under or around 2.5 milliliters unit per liter. And here where the confusion is going to occur right now in a few minutes. So this is the target, therapeutic target for those women before pregnancy, and it is actually the therapeutic target throughout pregnancy. And when the woman gets pregnant, immediately the dose should be increased by 30%. And I told you why, because the normal thyroid production increases by 30% early on. So we treat them with levothyroxine. And levothyroxine, as we all know, is a T4 replacement therapy, which has a half-life of 7 days, roughly. And we know that food interferes with it and has to be taken on an empty stomach, no food for about 30 minutes or after that. So essentially, if anything has any medication requires to have a steady state, and it takes about 3 to 4 half-lives for most of the medication to reach a steady state. So if you do the math, when you change the dose of levothyroxine, you need about 3 to 4 weeks before you reach a steady state and the TSH, you see impact on the TSH. So normally outside pregnancy, we wait about 6 weeks. Inside pregnancy, you wait for between 4 to 6 weeks. Changing the dose frequently is going to be inaccurate and can create a lot of havoc with those women for the frequent changes in the numbers. Levothyroxine has a very narrow therapeutic index. Missing a single dose can impact the TSH adversely. And this is really important that those women are educated on compensating for missing doses. So if she missed a Saturday dose, next morning she can take Saturday and Sunday doses. And if she missed 2 doses, she has to compensate these doses in order to avoid fluctuation in the free T4 levels, which can adversely impact the TSH. Theoretically, you can give the patient doses in 2 or 3 doses a week if things come to the worst. So early on in pregnancy, as I said, you need to aim for a TSH under 2.5, monitor for about 4 to 6 weeks. Now, mid-pregnancy, you might ease it off a little bit to about TSH except for 4. However, the recommendations are if the woman is euthyroid at 26-week gestation, you can discharge the woman from your service. And the reason why? Because the thyroid, the fetus hormone, is now sufficient. The fetus is not requiring any help from the mother anymore. So happy days. Once she reached euthyroidism, you can tell her you don't need to follow her anymore if that's the only reason she's attending with you. And after delivery, put her back on her pre-pregnancy dose. Now, the TSH aim of 2.5 creates a little bit of confusion because there is a therapeutic target for women who have underactive thyroid, and there is a normal range, and they don't correlate together. Think of HbA1c. We use 6.5% to diagnose diabetes, but we have different therapeutic targets, so it could be 7 or 7.5. So if a woman with subclinical or hypothyroid on treatment, the target therapeutic is 2.5, but the threshold to diagnose any abnormality is an upper limit of a TSH of 4. And that brings me over to what is the definition of hypothyroidism, of neurodetected hypothyroidism in pregnancy. And we normally say so as a TSH above the normal range and a free T4 which is completely suppressed. However, in pregnancy, if the TSH exceeds 10 millioninternational unit per liter, regardless of what the free T4 is, we label them as hypothyroidism. So, but always, when you find something like that, send a confirmatory test in order to make sure that this is accurate and it was done in the appropriate time. So once diagnosed, there's no difference from what I told you about. I normally start on a thyroxine 50, I don't use 25, and then we review them every 4 weeks, aim for a TSH under 2.5, as I just told you, monitor them closely, and once they reach euthyroidism at a certain stage, you can discharge them, and then usually I reduce the dose by 30 to 50% after delivery and see them 6 weeks later. Now, the controversies now occur with the subclinical hypothyroidism, because now it's defined as a TSH that's above 4, but definitely under 10, and you will have a normal free T4. And subclinical hypothyroidism, as Dr. Razvi told you yesterday, is a very controversial topic. And the controversy in pregnancy continues, and there is a huge consistency in the inconsistencies of all these studies, and the reason why the results are they diagnose subclinical hypothyroidism at various times. So you can have studies that start treatment at 35 weeks gestation. You'll have studies that started at 11 weeks gestation. And as I told you, the vulnerability is early on in pregnancy. And there are multiple cutoff points that they use in order to define what subclinical hypothyroidism. It has not been standardized. And because of that, you will have multiple issues in what exactly, if there are any benefit of treatment or not. So there are some studies that showed benefit of treatment, and I'll just pick one of them just to show you the issues with these studies. So this is a study that looked at the benefit between treating with levothyroxine versus no treatment with levothyroxine in subclinical hypothyroidism. And what they showed is if you treat those women, the miscarriage rates are actually lower. And always remember about the placental impact that I just told you about. However, while these are all good, the mean time for diagnosing and treating those women was 9 weeks. And almost all of the miscarriages in these groups occurred at 11 weeks gestation, so just less than 2 weeks of treatment. As I just told you, levothyroxine haven't even reached a steady state level or had a better impact. So it will all raise question marks about should we treat, should we not treat those women, and if we treat them, when will be the optimal time to treat them? So this is a recent meta-analysis, and I brought it just because it stays away from all the previous issues of how we diagnose hypothyroidism. Because it looked at studies that used the ATA 2017 cutoff point that I just told you about, and looked at randomized controlled trials and cohort studies. And when they put them all together, they found no benefit of treatment whatsoever. But when they split them and looked at only a randomized controlled trial, they found a benefit of treating those women early in the first trimester, in the reduction of miscarriage, preterm labor, gestational hypertension, and small for gestational age, all related to the placental development. All of this related to placental development, which is really good. There was no difference between anti-TPO positive and anti-TPO negative. Both benefited the same from the treatment in randomized controlled trials. More importantly, those long-term studies, which they showed no impact or no difference in treatment in the childhood motor, social, or behavior development. Because this is the first thing a woman with subclinical hypothyroidism, Mr. Google is going to tell her, your child is not going to be smart enough. So you can reassure her from that point of view. So as William Shakespeare asked, should you screen or not screen all women with thyroid disorders? And if you don't have a definite evidence of benefit from treatment, generally speaking, you shouldn't be screened. But there are recommendations on who you should screen for thyroid disorders in pregnancy, and you can follow that. However, regardless of which one you follow, there's no point of intervening or screening after the first trimester. No benefit whatsoever in any of these studies, and the woman will be taking medication to treat a number, more or less. So, if you diagnose subclinical hypothyroidism early, always repeat the blood test. In our unit, we have 20% of them when we repeat the test, they're actually normal. And now you follow the same as hypothyroidism. I use 50 in most of those women, and I follow the same kind of algorithm in treating them, and I aim for the same TSH of under 2.5. Now I'm going to touch base with hyperthyroid disorders in pregnancy very, very briefly. And pre-existing hyperthyroidism has multiple issues and all related to miscarriage and subfertility, more or less. But you have issues related to medications themselves because they've been linked to high risk of congenital malformations. So generally speaking, before pregnancy, you need to make sure that they eat thyroid, and usually you can offer them either surgery or radioactive iodine. Most of them will decline. And so what you need to do is try and get them as stable as possible on the lowest possible dose of carbimazole, in such a way that once they get pregnant, you stop the treatment. Or you can switch them all to PTU, use the smallest dose possible, again, in such a way that when they get pregnant, you immediately stop it. So how we diagnose newly detected hyperthyroidism, this is a very important part here, because the TSH in these groups must be undetectable combined with a free T4 that must be elevated. So this is a must, because a TSH that is suppressed, but you have a normal free T4, this is a normal combination in up to 20% of the women. Hence, you cannot make a diagnosis of subclinical hyperthyroidism during pregnancy. It doesn't exist. It can exist beforehand, but for me, it doesn't exist during pregnancy. So you have to have these two combinations, suppressed TSH, elevated T4, before you say it's hyperthyroidism. And most of the newly detected hyperthyroidism are actually gestational thyrotoxicosis. Very few of them have Graves' disease, and the rest are very rarely seen early in pregnancy. And gestational thyrotoxicosis is mostly driven by a very high HCG level, as I told you. HCG levels makes those women nauseous and vomiting, and they present with a high hyperemesis gravidarum. And there is a correlation, as you can see. HCG levels, as the vomiting increases, the HCG level increases, the free T level increases, and the TSH suppressed. And majority of those women, they don't have any thyroid, extra thyroid symptoms, and their anti-TRAP, which is really critical and make our life easy when we measure it, is negative. If you don't have anti-TRAP, you will kind of start doing this clinical guessing game and frequent monitoring. If you have the anti-TRAP, it makes your life easy. So those women don't require treatment. They should not be in any form of PTU of carbimazole. Some of them might require some beta blockers if they're very tachycardic, but supportive therapy is the most important part. Very rarely you need to give them anything. So if you have Graves' disease, whether you have it before pregnancy or newly detected, our main treatment is carbimazole on PTU. And both of them have risks to the mother, and we all know about these risks. But there are risks to the child as well. They cross the placenta freely. Early on, they are associated with high risk of congenital malformation, but the rate is about 3 in 10,000 of those children. But after 22 weeks gestation, they can suppress the fetal thyroid production because that's the maximum, that's what starts the peak production at that time. So as much as possible, we try not to use them. Anti-TSH receptor antibody has a similar impact. So they cross the placenta. They might actually impact the fetal thyroid hormone because there is inhibitory and stimulatory TSH receptors. You're not sure which one of them kind of concentrate more, but most of the time it's the stimulatory part, and they can cause fetal hyperthyroidism. And we need to measure them at baseline if we can, but we do need to measure them at 22 weeks gestation. And if they're above the 3 times the upper limit of normal, our upper limit of normal is 2, makes our life easy, so 6. The fetus is at high risk of fetal hyperthyroidism. They need monitoring by our fetal medicine colleagues for any signs of hyperthyroidism. So what you're going to do over here, if you treated those women, you put them at high risk of complications and the fetus at high risk of complications. If you don't treat them, they will be in a lot of trouble with that. So high risk of miscarriage, the mother will go through all the complications of uncontrolled hyperthyroidism. So you're damned either way, so you need the balance here. And here is one I say, those women should be managed in a specialized clinic with a specialist in this area because they need to be monitored very delicately. So at conception, as much as possible, we try to stop the medications if we can. We monitor them every 3 to 4 weeks. We never attempt to get the TSH back to normal. The normal free T4 here is actually, I told you, it's usually suppressed. So what's a normal free T4 or acceptable level of free T4 is up to 50% above the upper limit of normal. In our institute, it's 20, so you can go accept up to 30 picomoles per liter. But that is provided that the woman does not have symptoms of hyperthyroidism and she is gaining weight. Her resting heart rate is under 100. So you have to combine the two together. Symptoms plus free T4 levels. You can't look at them alone, and you make sure that those women are gaining are gaining weight for the pregnancy. So if you want to treat, first trimester PTU is preferred. After that, carbimazole is preferred. And we try not to exceed 20 milligrams per day of carbimazole. Anything above that, the fetus has high risk of hypothyroidism and a goiter. Now, as I told you, we need to monitor the anti-TRAP, and if it's high levels, we need to monitor the fetus. The good thing is, in Graves' disease, about 60%, we just analyzed our cohort, it's actually 75%, don't require any treatment. Anti-TRAP goes down, and they do better, and that's really good. Now, this is just for the women, so if after delivery, they can take the medications, they can breastfeed. They usually get a wrong message here. Up to 20 milligrams of carbimazole is safe for breastfeeding. My last part here is related to euthyroid anti-TPO positive women. And those women that there has been a lot of controversies, many studies that showing that treating them will reduce the risk of miscarriage, so on and so forth. However, there has been studies that showed that treatment doesn't matter. This is a large study from the United Kingdom that looked at women who have problems. They are either miscarriage or have infertility. They were euthyroid, they're anti-TPO positive. They gave them levothyroxine. There was no benefit of that in any of the outcomes. If you're skeptical about one study and you want it to be confirmed, there is a study that came last year that was done in Scandinavian countries, similar design, similar risk factor, no benefit of treatment. And that's where we and our colleagues in obstetric and gynecology do not agree. Still, because they don't want them to give levothyroxine, they want to give them steroids as well, of anything. So no benefit of treating them, and it doesn't seem that anti-TPO plays any role anymore or has any other impact apart from increasing the risk of progression of thyroid disorder. But during pregnancy, it doesn't dictate what you need to do, basically, in terms of treatment. It doesn't impact your decision. So my key takeaway messages here, as I told you, it's very critical to understand the changes that happen during pregnancy, to avoid over-treatment or under-treatment of those women and over-diagnosing, especially over-diagnosing subclinical hyperthyroidism. I don't think the notion that just giving a medication that has a low side effects is good. Taking the medication early in the morning, empty stomach every day is stressful, is a bit of work for women. And if they don't need to do that, they should not be taking that. And preconception management is really critical in order to have an uneventful pregnancy. Now, you need to establish your own local reference range, agree in this reference range between the different institutes so the women do not get mixed messages. And I think the ATA guidelines 2017 make things a little bit easier. And I thank you very much for your attention.